Shut up! Mental illness is something that most people struggle with at some point in their life that causes big issues and creates hurdles for people to overcome. But specifically, mental disorders can cause lifelong issues that need to be dealt with in order to achieve homeostasis. That being said, there are plenty of treatment options in order to deal with these illnesses or disorders, such as behavioral therapy, talk therapy, or speech therapy, but specifically, there is psychopharmacological therapy. This includes being given specific drugs or chemicals that alter brain chemistry in order to treat the underlying condition. The main goal in a diagnosis is to find the most accurate aligning condition that the patient might have and finding the best possible treatment that allows the patient to overcome or cope better with what they have and being able to eventually leave the medication that they are on. There are two categories whenever it comes to medication options. The first category being psychotropic. These medications include non-benzodiazepine anti-anxiety medications, non-stimulants, antipsychotics, mood stabilizers, and antidepressants. These mainly individually target certain receptors through reuptake inhibition, receptor blocking, or calcium-sodium channel blocking. Antidepressants more so, though, focus on transporter pathways and not particularly the receptors themselves per se. The second category includes psychoactives. These include substituted amphetamines, marijuana, benzodiazepines for anxiety, MDMA or considered Molly, and or ketamine. These work by largely targeting dopamine or GABA receptors with partial serotonin action. Other psychoactives include psilocybin, LSD or LSA, DMT, mescaline, or peyote. These are considered psychedelics that largely target serotonin receptors and are major agonists. The main difference between these two categories is their availability, their scheduling, and their potency. Psychotropics like SSRIs and NDRIs tend to not be scheduled or have a very high scheduling. This means that they have very low abuse potential and are a first-line aid for illnesses such as anxiety or depression. Psychoactives, however, tend to be highly scheduled and controlled, and typically have high abuse potential. Medications such as substituted amphetamines like Adderall, Dexedrine, or Vyvanse have high abuse potential but are extremely effective in the treatment for ADHD. The other portion of the psychoactives category, also known as psychedelics, are all Scheduled 1, which means that they have very low medical usage, but in other countries they are being tested for the treatment of PTSD and anxiety in general. Using this information, you can utilize it to know what to prescribe to a patient and when. For example, whenever a patient comes in presenting with more minor symptoms of an illness such as generalized anxiety disorder or other unspecified depression symptoms, it might be a good idea to prescribe them with a low-tier medication like an SSRI or an NDRI. Whenever a patient comes in presenting symptoms of a much more extreme condition or disorder such as ADHD, autism, or even psychosis-related disorders like bipolar disorder or schizoid personality disorders, that might be whenever you use lower scheduling medications or medications that might have a longer lasting impact. For example, with psychosis-related disorders, you might want to use an antipsychotic. For disorders such as ADHD, it would be helpful to prescribe substituted amphetamines to manage the symptoms. Here, I interviewed somebody that used to work in a psych ward and used to encounter every single kind of mental illness and mental disorder and would accordingly provide treatment to each and every one of her patients. What's your background in psychology or handling mental illnesses or disorders?
I have been a nurse for about 14 years, studied psychology fairly extensively while in college, with the last 2 years being spent working as an RN on a behavioral health unit, which is an inpatient unit in the hospital where we treat mental illnesses.
How tame or extreme would the mental disorders be in observed patients?
There was a wide variety ranging from mild to life threatening, severe. But typically, in order to be admitted to an inpatient unit, there had to be at least some harm or risk of harm to self or others.
What were the most common or uncommon illnesses you've seen while as a registered nurse?
So between working the floor um, on the medical side as well as working the inpatient mental health side, I've seen things that range anywhere from mild anxiety leading up to panic attacks, suicidal ideation, all the way up to severe schizophrenia with hallucinations and delusions.
If any, what were the side effects from pharmacological treatment?
There's a wide range depending on which medications were prescribed or the patients were taking. Some of the milder anti anxiety medications caused more mild symptoms, sleepiness, whereas all the way up to some of the stronger antipsychotics could lead to long-term, sometimes permanent conditions, particularly with long-term use. Things ranging from tardive dyskinesia would be an example of one, which can be permanent. It's involuntary muscle spasms, facial movements, involuntary muscle movements that sometimes do not go away after long-term use.
Were the treatments often effective? If they weren't, what were the circumstances of the patient or the condition?
So it varied again, it varied widely. Some treatments would work for some patients, whereas you turn around and you have a patient with the same condition where the same treatment would not necessarily work. One of the bigger problems that we ran into, particularly with patients with schizophrenia, would be the medication would work while they were taking it. However, once the patient felt that they were better due to their condition, they would feel that they no longer needed to take their medication and would ultimately regress back into the original condition. Paranoid schizophrenia was particularly challenging due to the patient's paranoia. The patient typically did not want to be started on any medication. One of the ways to resolve that was they have come out with long-acting injections where the patient has to go in maybe once a month, maybe once every 3 months for the injection, and that's the only treatment they have to have until time for the next injection 3 months later. So it stays in their system longer and it's a lot easier to manage for those particular patients.
Did you notice a difference in specifically offering psychotropic or psychoactive substances to the patients? If there was or wasn't a difference, what would it be?
A difference in how they responded to it.
Mm-hmm. Difference in effectiveness or side effects?
Well, again, with the long-term use of the antipsychotic medications, that's where you see the majority of the more severe side effects, such as the tardive dyskinesia. And again, that's with long-term use. There are medications that we can give to help with some of those symptoms. For instance, Cogentin would be one that would be taken alongside an antipsychotic medication in order to prevent some of the more acute or immediate symptoms that you see, such as muscle stiffness and things like that. But again, long-term use a lot of times will lead to a permanent condition strictly from the medication usage.